So, good morning, good afternoon, and good evening. My name is Tim Devling, and I'm the Director of Sales and Applications here at Ithera Medical. It's with great pleasure that I welcome you to our continuing webinar series. Today, we're going to listen to Dr. Max Masthoff talk about the use of MSOT for clinical vascular imaging. The webinar will last for about 40 minutes with time for questions at the end. Should you have any questions, if you maximize the go-to tool, you can see a question box and type them in there, and we'll look at them towards the end. We'll also be recording the webinar, and we'll send you a link to this over the next few days. So we welcome today Dr. Max Masthoff. Max is radiology resident at the University Hospital Munster in Germany, where he also completed his medical training. His research interests are in MRI, MSOT, and interventional radiology, where he and his colleagues have worked on a number of interesting and pioneering clinical MSOT research projects. So we welcome Max today, and over to you, Max. Thank you.
Yeah, thank you, Jim, very much for the introduction. Welcome, everybody, and thanks to Ithera for the invitation to the opportunity to hold this webinar on clinical vascular imaging with MSOT. So the aim of this webinar is to show you some overview on clinical applications for MSOT regarding vascular imaging. For this, I will provide some of our own work, but also give an overview and name some publications which were very interesting from other groups on this topic. So happy to ask you your questions in the end, like Tim said, and we will just start then right from the beginning, since I was told there most probably some clinicians also in the webinar which are not too familiar with optoacoustics. I will just start with a brief introduction in the technique, which most of you will know. So MSOT is relying on the optoacoustic effect, which is quite known for a time in the past, but MSOT uses this effect by using laser excitation in the near-infrared range, which leads to a thermoelastic expansion of the exposed tissue. So this thermoelastic expansion then by the optoacoustic effect leads to an emission of ultrasound waves, which we can detect just we do in ultrasound imaging. So we have a light in, sound out principle here in optoacoustics.
Max, could I just interrupt for a second? I don't think your slides are progressing.
Okay. This is true. The question is why. Work for now. It says paused. Always wants to pause me. Now
there we go.
Yeah, it somehow paused me maybe with the time. I'm just very sorry. There are always some technical problems with the online things. So yeah, we are on the right slide now, where I just was about to explain the optoacoustic principle. I started here with the laser excitation on the left side, and then we progressed over the thermoelastic expansion, which is due to the laser excitation of the exposed tissue. And this then leads to an ultrasound emission of ultrasound waves by the exposed tissue. So the principle of multispectral optoacoustic imaging is now that you do the laser excitation at multiple wavelengths at the same time. So this leads to the advantage that you can make use of the different absorber properties of intrinsic biomarkers like hemoglobin, which is shown here in the left bottom of the slide, where you see that deoxygenated hemoglobin in blue here is completely different to the oxygenated hemoglobin in its absorber properties at the respective wavelength. You can go to other intrinsic biomarkers like fat or water as well, which is some of recent more used in recent studies. I will show you later. So the most of the work I will present today from our group was done with the MSOT Acuity Echo, which is, for the clinicians of you, hybrid MSOT ultrasound engine, which has a handheld probe, which is very similar from what you know from the ultrasound imaging. You can use it at the patient's bedside here, and you have like a real-time live image of your optoacoustic signal, of your ultrasound signal, and you can do an overlay mode as well. Due to the laser excitation, you have to protect your eyes and the eyes of your patients by the laser safety goggles. So the idea of the spectral mixing while scanning with this handheld probe is then that you get an idea of your intrinsic biomarkers like oxygenated hemoglobin or deoxygenated hemoglobin in real time. So if you think about all the absorbers you may use MSOT for, you have these endogenous absorbers like hemoglobin, as I mentioned, and then you have others like melanin, lipids, water, which all have different absorber properties you can use for optoacoustic imaging. So on this left side here of the table, you don't need any contrast agent to assess these parameters. Of course, there are some exogenous absorbers which you can bring also in the patient, which has been done as well for other applications, like for using indocyanine green, ICG, methylene blue, or gold or silver nanoparticles, which gold and silver nanoparticles in GFE is more used in the preclinical setting, actually, but indocyanine green and methylene blue has been used in patients for other imaging modalities, but also starting up with optoacoustic imaging. But to keep it simple, you have these endogenous absorbers here, which you can assess in a contrast-free manner. So if you think about hemoglobin, of course, you think of vascular structures to assess with optoacoustic imaging. And if you think about vascular structures, of course, in a clinical setting, you go for cardiovascular diseases. Just to mention it here in the beginning, there are a lot of other clinical applications evaluated for optoacoustic imaging, for e.g. With a hemoglobin and a combination of inflammation and cardiovascular imaging, for systemic sclerosis, imaging of the skin, with melanin, who has been evaluated by the group in Essen, for melanoma imaging and melanoma metastasis to lymph nodes by this group. And then you have metabolic applications like in brown adipose tissue, or you have lipids going also for cardiovascular imaging, but also for in the context of this brown adipose tissue, imaging. So you have a whole range where you can use your biomarker imaging in clinical settings. Today we will concentrate here on cardiovascular or vascular imaging mainly. And to start with, one of the first applications, not by our group, but Tarutis et al., published in 2016 Radiology as one of the first applications of MSOT for clinical vascular imaging. They had already just a handheld probe here with an ultrasound transducer and the optoacoustic imaging array. And what they did is they just go to healthy volunteers, and they were actually able to image the vessels of the foot, the bigger ones like the arteria dorsalis pedis on the back here of the foot, or the arteria tibialis posterior, which is on the inner part and at the back of the foot. So here in the image you can see that you have a clear identification by optoacoustic signal shown here in red due to the hemoglobin, oxygenated hemoglobin signal of these arteries. You can even go to smaller vessels and assess microvascular dysfunction, like we have done that in systemic sclerosis here, but they have done it for the toe in healthy volunteers with quite a good spatial resolution. And so MSOT enabled here to image these vessels of vascular structures in the subcutaneous tissue without using a contrast agent. So to go to, if we think about what we can do in healthy vessels. We thought, okay, maybe we can go also to non-healthy vessels like in vascular anomalies. So vascular anomalies, just to give you a brief introduction in the clinic background, can be divided in vascular tumors where you have a high cell proliferation of the endothelium. So you have, from the histologic background, a neoplasia, and these can be benign, like in hemangioma, but can be malignant as well in hemangioendothelioma for EG. But you also have benign lesions called vascular malformations, where you have dysplastic vessels. So the wall of the vessels is not there in the right way, and they can be further divided in so-called venous malformations, which are the most common ones, and 4G arterious venous malformations. While venous malformations have only dysplastic veins, so they are slow flow. The blood is only, like in veins, flowing slowly in these malformations. In arteriovenous malformations, instead, you have an arterial inflow, a fast flow inflow in these lesions. And the reason to distinguish both of them is that you treat them completely different, and the outcome of this treatment is, from the prognosis, completely different in the either or the other case. So in vascular malformations, you have a dysplastic change of the vessel wall. So you have not a neoplasia, but a dysplasia. Since these lesions are always innate and progress over time, we have a young patient collective. Usually they present around 6 to 15, 18, and then in female patients around pregnancy, where you have a lot of hormonal changes which stimulate the growth of these lesions as well. So we thought maybe this would be a topic for MSOT to be assessed. So current imaging is based on anatomical imaging of these lesions. You see these cavernous, hyper-intense lesions here in MRI. You have some dark spots, which you see throughout this video here, in the lesions here and here and here. And these are like the local thrombosis in these lesions, because the blood is flowing, has such a low flow in these lesions, and that is what causes the symptoms of the patient, the local thrombosis within the lesions. Importantly, you don't have an arteriovenous, you don't have an arterial inflow in these lesions on MRI angiography. These lesions, you go to therapy in interventional radiology by doing a percutaneous needle injection and sclerosing your lesion, with the idea to induce tissue scarring here, and so there's no further blood flow to the lesions. But as you see, these lesions can be very diffuse within the tissue, and you will hardly ever get all parts of this. So patient monitoring or therapy monitoring is an aspect which can be improved in these patients. AVMs instead, they do have an arterial inflow, as I mentioned. Here's an example at the knee. You have an MRI of the knee here with an MRI angiography, and you see these arterial vessels reaching out to the lesion here, and then you have an early injection of the veins of the lower extremity here on the right side, which you don't have on the healthy contralateral side. This is because you have this shunting between arteries and veins. These patients you treat completely different. You go usually to an endovascular approach, and then you kind of glue your shunting region and the arteries going to the lesion. So it's not only important for the clinical prognosis of these diseases to differentiate between AVMs and VMs, but also from your treatment strategy to choose. So the problem with these vascular malformations is, from the initial base, you have a high rate of misdiagnosis in these patients, up to 47%. Like a big study here from 2011 with over 6,000 of these rare diseases. and 47% of these patients had a misdiagnosis in the beginning, which is unbelievably high if you think that you have these young patients suffering from these malformations. Then you have your diagnosis, which is limited due to morphological information and can be limited also in the point to find the arterial inflow to the lesions. Because if you don't find your artery going in the ultrasound to the lesion, you have problems identifying this as an AVM. So most of the patients go to MRI, repetitive MRI, both for diagnosis and therapy monitoring. If you think of the young patients, they may need anesthesia for this MRI, they need maybe contrast agents, and you have a higher effort to get this MRI for just, let's say, the whole leg. So we thought MSOT might be a good option as an easy and real-time tool to assess the intrinsic biomarkers of the lesion itself to distinguish between AVMs and VMs for EG. So in our study, we did go for 6 patients with VMs and 6 patients with AVMs, which is quite good if you think that this is a very rare disease. And then 2 of the patients with VMs we scanned before and after sclerotherapy, and 3 patients before and after endovascular embolization of the AVM. So this was designed as a pilot study, and we thought to look first at the HbO2 over HbR. This is the deoxygenated hemoglobin ratio to differentiate between the lesions. So we scanned, as I said, with the MSOT Acuity Echo, did go with the probe for the lesion and always the contralateral healthy side of the patient to compare the lesion parameters with healthy tissue. Coming to the results, we saw that this ratio of oxygenated hemoglobin over deoxygenated hemoglobin was significantly higher for AVMs than for VMs, and both were higher than the comparable healthy tissue on the contralateral side. So interestingly, MSOT was able to distinguish here between the clinical important differentiation of AVMs versus VMs. Regarding therapy monitoring, we had 3 patients before and 3 patients after therapy, where you see that patients who have had already an embolization showed the ratio more closely here to the healthy tissue of the contralateral side and dropped in the ratio, compared to the patients who have not been treated before. 2 patients were scanned directly before and 24 hours after the embolization, and here we saw that 1 patient dropped to healthy values, while the other, in red here, did not show this great improvement in HbO2 over HbR ratio. So what was going on here? First, the patient who dropped to healthy values, as validated by angiography, he had a complete embolization in the procedure. So you see it in the MSOT images here. You have a clear drop in HbO2, Hb values due to the embolization. And that is important. You had it in 24 hours after the intervention. Usually you have to wait quite a while, a couple of weeks, to see a therapy effect in MRI, because you have to wait until the scarring is there to see what you have done with your intervention. So to see this effect right here that early was quite impressive for us. The other patient instead only had a partial embolization, so we had still perfused parts of the AVM, and MSOT indicated this with a still high ratio of HbO2 over HbR. The signal here was still high, so at least in this 1 patient, MSOT indicated that there is further need of therapy as well, and so we think MSOT might be a good tool to do therapy monitoring in these patients too. of course, this has to be evaluated in a greater patient number. For the venous malformations and the percutaneous sclerotherapy, both patients dropped to healthy tissue. You see there's nearly no difference in the ultrasound imaging, which you only had before, and with MSOT, you see a clear difference of the intrinsic biomarkers, in this case, hemoglobin of the lesion. So, if you think about hemoglobin in cardiovascular approaches, you might go with first to more common diseases like peripheral artery disease instead of these more rare vascular malformations. So PAD is a common manifestation of arteriosclerosis in the limbs and is associated with the cardiovascular morbidity and mortality. And regarding the patient, the individual patient, the limb events caused by PAD have a high impact on their life quality. Again, PAD imaging is also limited to just morphological information or flow information. You just go with all your imaging methods, either MRI, CT, ultrasound. You look at the stenosis itself, see how much is the stenosis occluding the vessel. You see how much is the flow increased or decreased in the macrovascular vessels, but no one can look at the affected tissue by this disease. No one has an idea what is going on in the affected tissue, which is causing the problems to the patient because the muscle or the subcutaneous fat or the skin is not perfused anymore. So again, we thought maybe this would be a good application for MSOT in a more common disease than in the vascular malformations. So this is from a study which is under review for now, which was in collaboration with the Nincia Christus lab and Angelos Kalas in Munich, where we performed a two-step study design. First of all, we did an experiment in healthy volunteers with a temporary occlusion, cuff occlusion of the upper leg, and performed MSOT scanning at the lower leg, the calf, for subcutaneous fat and muscle tissue. We assessed our hemoglobin values and the derived parameters of total hemoglobin and the oxygen saturation. In the second step, we did go transfer the approach to patients, where we scanned them before and after an intervention where you dilatate or stent and stenosis in these PAD patients. So first of all, the cuff-induced arterial occlusion measurements in the 4 healthy volunteers here as a pilot study. You see, if you have a look on the table on the left first, you see that with the minutes of occlusion here, 1 to 3 minutes, you see a drop in HbO2 and strong increase in the deoxygenated hemoglobin because no fresh oxygenated blood can reach the extremity anymore. The deoxygenated hemoglobin, as expected, rises here in the affected tissue. After deflatation, so there you have a reperfusion effect, which is well known as a mechanism in humans and animals. Then you see here increase in oxygen saturation and hemoglobin, especially the oxygenated hemoglobin in the second minute after cuff deflation, representing the reperfusion of the affected tissue. On the right side here is the graphical illustration of these experiments. Just as in the table, you see that you have an increase in deoxygenated hemoglobin over the time of occlusion, which drops after reperfusion because fresh blood is reaching the limb now, and you have a drop in HbO2 slightly only, but then especially in the reperfusion phase, you have a high amount of oxygenated hemoglobin reaching out to the tissue. Your MSOT signal represents this as well. If you want to have a look here as a HbO2 signal, slightly decreasing but then increasing after cuff deflation, and vice versa, the deoxygenated hemoglobin in the upper row. So the point to take home here is that MSOT is able to do a real-time assessment of tissue parameters like hemoglobin in the tissue under the change of circumstances, like an occlusion of the arteries or the reperfusion effect here. And you can really do it without any contact agent. The next step was to go to patients, and that's where we collaborated here with Angelos Kalas in München. In this pilot study, again, 4 patients pre and post operation were compared to healthy volunteers. As you see, there was not a significant, just a trend here from pre to post operation in the deoxygenated hemoglobin, but in the oxygenated hemoglobin, you had a significant change from pre-operation to post-operation situation in the affected tissue after treating the underlying stenosis in these patients. Same as for the oxygen saturation and the total hemoglobin. Of course, since these measurements here post-operation were performed 24 hours after the intervention, there will be a reperfusion effect in these results. So regarding long-term outcome and long-term measurement of MSOT, there's a lot of work to do in bigger studies, but very interesting topic in my opinion, to assess this in the future, how MSOT signaling as assessed before and directly after the intervention correlates with outcome or restenosis rate would be very interesting in the future as a clinical application, because then you would establish an imaging method which images actually the affected tissue and not the anatomical information of the stenosis. Okay, for the next topic, I would like to think about how to improve these cardiovascular imaging with MSOT as it is right there. There has been work by Young et al. From the München Lincia Christos group in photoacoustic, just published last month, where we collaborated in, and they used the prior mask of the ultrasound imaging, which you do acquire at the same time in the hybrid optoacoustic ultrasound imaging approach. And they used the information you gain with the ultrasound imaging to improve the reconstruction of the optoacoustic imaging. You can see this here on the right side. There's a clear improvement by the prior integration of the ultrasound mask to the optoacoustic reconstruction regarding the signal to noise ratio using this method. So this seems promising to go to humans too, and they did this in the paper as well. The first attempt was here to improve the reconstruction of the radial artery imaging with MSOT. You see the radial artery here in the ultrasound imaging, and this was used as the prior mask for the optoacoustic reconstruction. And as you see, it's hard to see the whole vessel here because you have a lot of signal from the first hemoglobin reached by the laser light here at the beginning of the vessel. But using the reconstruction method, you can identify now the whole vessel here within the tissue. This works more or less also in the deeper tissue up to 1 centimeter here. The radial artery is here in a deeper tissue due to more subcutaneous fat. But again, here I actually don't see anything in the optoacoustic imaging, or I would not be sure at all. This is the radial artery. At least here you get an idea where to look at. In the paper, we did this reconstruction method not only in healthy disease. We did go to patients, and that's where we collaborated in and imaged some patients with carotid plaque imaging here. Again, the reconstruction method improved the the imaging of the carotid artery here compared to the standard reconstruction. We had in the beginning really problems to image the carotid artery due to this high signal at the beginning of the vessel, and compared to the radial artery for EG, and the carotid is deeper as well in the tissue, so both hampered somehow the carotid artery identification in the MSOT imaging. But maybe there will be some improvement further with this image reconstruction methods using the ultrasound imaging as a mask to reconstruct your MSOT imaging. Importantly, as shown here for healthy patients, the reconstruction method does not do here some false positive results for the plaques. This looks mainly the same here from in healthy volunteers not having any plaque. Like the patient above here. And shown in the graphs here on the right, this improved the contrast to noise ratio and the intensity ratio in the patients, and showed that with the reconstruction method, you could distinguish between patient and healthy carotid wall plaques, or healthy tissue or healthy wall in case of the healthy patients. So this might be a topic to further address. There are many others regarding the handheld probe itself and the spectral unmixing, but also, and this I would like to show you with this paper, there can be some advantage of using ultrasound and optoacoustic imaging at the same time. Another example here for the carotid artery by the Radzansky group, Ivankovic et al. Just published in Radiologist 2019. They use a different probe here with a spherical array detection geometry, and they could really perform impressive images here of the carotid bifurcation in real time and in a 3D visualization. Just thought as an outline here, there's a lot of interesting stuff to come for vascular imaging in this regards as well. Just as an introduction, as an outview for you guys, there's not only veins and arteries imaged by MSOT. There are first attempts to assess the lymphatic vessels as well, just recently published in Journal of Clinical Medicine by a Japanese group. They did use, and that's a nice example for using an exogenous absorber. They labeled the lymphatic vessels by injection of indocyanine green, ICG, and they could image with the Acuity system the lymphatic vessels and use these images generated from MSOT to guide their surgery to perform procedures at the lymphatic vessels. Quite high resolution here as well, and you could really see the lymphatic vessels along the arteries, which is like a very interesting system to assess the lymphatic vessels. And just besides MSOT, there's a lot of research put at the moment in the lymphatic system. So this could be an evolving field of MSOT as well. So this last paper here, just as an outview beyond the blood vessels, and thus I would like to conclude that MSOT is a novel imaging approach enabling for non-invasive and quantitative imaging of the intrinsic biomarkers, which most of the applications at the moment are evaluated in a contrast-free manner. For us clinicians, it's very promising that this happens as a real time, as we are used to from ultrasound imaging, which you can use in this hybrid approach for your anatomical co-localization, making it easy for us to apply MSOT imaging in our routine, or I hope it will be easy for us to apply this in the future. You can do it at the patient's bedside. You don't need anesthesia. You don't need anything else. It doesn't hurt the patients. So you just have to put the safety goggles on, and then you're fine to go. Translation into the clinic seems promising also for vascular diseases. I hope I could show you that. And yeah, we hope there will be a lot of more research to come to translate this technique more and more into the clinics. So for this, for now, thanks for your attention, and I'm really happy to ask any questions if there are.
Thank you very much, Max. That was a really interesting talk, and we've got quite a few questions that have come in, so we'll probably spend the next 10 or so minutes on the question section. From the top, let me just read through these. You mentioned a high rate of misdiagnosis for vascular malformation with traditional approaches. Given your limited cohort of patients, can you comment on the accuracy of the optoacoustic technique?
So in this patient cohort, the diagnosis was secured by histology and the other imaging modalities. So we included patients where we were sure. But there was no MSOT signal where we were unsure that this is an AVM or VM. We were always sure the MSOT signal, then that we can differentiate between the both. But there certainly will be some overlay which we didn't assess in this small cohort. You have many lesions in where you have bigger or smaller venous or arteriovenous malformation parts. They can be very heterogeneous sometimes, so there will be an overlay which we haven't assessed yet, and we will see that in future studies, I guess. But from what we know from the patient cohort we assessed, there seems very promising to have a high accuracy, but you have to be careful. It's only 6 patients each.
Okay, so I mean that leads to the follow-up question we have here is you studied 6 patients in this pilot study. Do you plan to scale this up to a larger cohort?
Yeah, we are on it. Yeah, we would like to, we have to establish the system here for a longer time period at our site here in Munster, and then Moritz Wildgruber for EG in Munich is doing muscular malformation treatment as well. So to include more and more patients, because this is a rare disease, we plan like a multi-center approach in the future. But this, of course, needs some time for planning, but this is definitely something where we would like to go at.
Okay. Question based on the lymphatic work that you showed, the most recently published lymph imaging. ICG is used for blood flow imaging in lymphatics and fluorescence-guided surgery. Do you think it could be useful to image blood flow in vascular imaging?
It has been used, I think, for in animals for vascular flow imaging, and we did some self-experiments with ICG and carotid imaging, but this is just very, very preliminary. But you basically enhance with ICG your MSOT signal. So if you go to flow measurement, I definitely guess this is possible with ICG to gain some flow information, especially reconsidering the work from Radzansky et al. Using 3D reconstruction of your MSOT signal.
Okay.
But as far as I know, there's no work really assessing blood flow with ICG in humans, but I may be wrong.
And then a question, which again I feel the answer will definitely be no, is there's been in vivo work done using optoacoustic imaging of a mouse's heart. Do you think this will ever happen in humans?
Yeah, I of course know the work from the cardiovascular or cardiac approaches of MSOT in mice, which shows really impressive results to image the myocardial infarction. Basically, in patients, you don't really have the time to do these approaches. You go with the catheter in and try to treat the patients, but if you think, for EG, of heart operations at the open heart or heart transplantations after an ischemia reperfusion phase of the transplanted heart for EG, you could think that then the surgery doctor goes for an MSOT assessment of the transplanted heart or of the open heart. Then you get much closer to the heart, and you don't have these penetration depth problem. But as far as I know, this has not been done.
Okay. Following on question here is, can you quantify the perfusion status of a specific ischemic lesion? I wonder if that would be possible.
So do you mean of the affected tissue in ischemia for EG? Or?
Sorry, next bit of text has come in. For example, in a leg ulcer or a digit, a gangrenous digit. So could you, okay. So superficially, could you measure the perfusion of a damaged region?
Yeah. So what we are aiming at in the PAD case or in the PED setting is that we risk stratify the patients with MSOT. So we plan or we envision that we scan the affected limb and then put like a risk stratification for the patients to develop the necrosis or gangrene in the future. And so to guide the indication for therapy as well. Of course, this is a long-term future vision, but that would be the plan to go for. And because we actually in the patients we want to prohibit the necrosis of the toe, for of course, yeah. We want to be earlier than we do now, yeah.
Okay, so
helps us with that.
So probably yes, the MSOT can image such changes in perfusion, but you think that it's much better as a predictive tool?
Yeah, of course. MSOT will image lower parameters for oxygenated hemoglobin in these patients. I guess this is pretty easy doable. But what does the MSOT markers say us then if we assess them, and especially in comparison to other patients, this needs to be assessed in the future.
Okay, so final two questions, and this is an interesting one actually, is what's the difference between a hemangioma and a port wine stain?
So a port wine stain is more a capillary malformation, and the hemangioma is a tumor. So it's a benign tumor with a neoplasia of the cells. Only actually the actual hemangioma is there at birth and then goes away from alone, or you do some medicamentous treatment or laser therapy. And the port wine stain is actually a malformation. So on the other side of the table I have shown, it's a complete different entity. It's just put together in vascular anomalies in these classification. So I recommend to go to the classification of the ISVVA. This is the International Society for Vascular Anomalies. There's quite good explained in the current classification system.
Okay, thank you, Max. And one final question is, what are the advantages of using MSOT for vascular malformations versus standard angiography methods?
Yeah, so first of all, the angiography methods are invasive. And in the patients, like for in the venous malformations, you don't have to do an angiography. We actually want to pre-screen the patients before the angiography to only take the patients to angiography who needs to be there. And we think MSOT may be an option to stratify the patients better, to whom to take to angiography and whom not.
Okay, so yeah, there's a few extra questions. We can follow up with those at a separate time. One or two I think would need a bit more of the detailed discussion. But I want to say thank you very much, Max, for a very interesting talk on both your work and the kind of state of the research in the field at the moment and how it's developing. And thank you to everybody who joined the webinar for staying with us and for taking the time to look at this interesting clinical research technology. So again, thank you, Max.
Yeah, thank you, Tim, and everybody else listening.